الرحمن الرحيم. 3 2 1.
Hello everyone. It's Thursday night, 9 p.m. exactly is CEC time. And every Thursday we have the clinical discussion forum with a new hot topic. Today we have sudden cardiac death. It's an important topic in the cardiology. And we have today with us two eminent electrophysiologists. Dr. Ahmed Damati, the lecturer of cardiology, Cairo University. He is a consultant of electrophysiology and pacing. And Dr. Mahmoud Abu Al-Ata. Dr. Mahmoud Abu Al-Ata, he is an electrophysiologist fellow in the Cairo University. Today, we will have a case-based discussion for different cases of sudden cardiac death. And I'm sure that we will enjoy it. And the mic with you, Dr. Ahmed Damati.
Good evening, everyone. It's my pleasure to be with you today with this very elegant platform. And we hope that our presentation today will be informative and useful. And we always encourage the back and forth discussion, because this is always what makes our presentations fruitful. Thank you very much. Hope you enjoy the next hour and a half or so. I'll give the mic now to Dr. Mahmoud Abu Al-Ata, who will start the presentation.
Thank you, Dr. Ahmed. I would like first to thank you for allowing me to participate in this important topic, and thank the panel for allowing me to have the pleasure to participate in this prestigious channel, and I hope it will be helpful presentation.
You may start sharing your slides, Mahmoud.
Okay, everything, the first slide has appeared.
Yes, dear Mahmoud, you may start speaking.
Okay, we will start. Okay, first we have to look for a few definitions that we will use throughout this presentation. The first definition is what is aborted cardiac arrest. It is an unexpected circulatory arrest occurring within 1 hour of acute onset of symptoms, which is reversed by successful resuscitation maneuvers. The second important definition is primary prevention of sudden cardiac death, which refers to therapies that we use to minimize or to tackle the risk of sudden cardiac death in patients who had not yet experienced an aborted cardiac arrest or life-threatening arrhythmias. The last definition is secondary prevention of sudden cardiac death, which are therapies that we use for patients who are at risk of sudden cardiac death and they already had an aborted cardiac arrest or a life-threatening arrhythmia. Looking at the epidemiology of sudden cardiac death, we can appreciate that the majority of these patients have coronary artery disease, which means that it is the most important substrate that we have always to tackle while we are managing these patients. Back in the 1991, Solved study was the first study to show an intervention, which is ACE inhibitors, that can reduce the risk of sudden cardiac death in patients of ischemic heart disease. And during these 1990s, more studies added benefit for the topic of sudden cardiac death in the name of beta blockers by the CYBES-2 and the Copernicus trials. In late 19th, aldosterone, the RAILS study, the RAILS study showed benefit from aldosterone antagonists. And finally, in 2005 and 2009, the companion and CARE-HF studies showed the impact of ICDs on mortality. So we have two parts for management of sudden cardiac death in patients, namely or mainly of ischemic heart disease, but the general term patients who are at risk of sudden cardiac death. Medical treatment, which evolved over the years by several studies, and finally ICDs. So let's start with the first case scenario. Someone is doing. Dr. Muhammad, can you hear me? Can you hear me? There is someone doing.
Yes, we can hear you. I
Um,
don't know where this
I
guy
would,
came
I,
from. Stop
I would,
sharing and share again, please.
I would appreciate everyone if we stop sharing the annotation.
Okay, reshare again, please.
Okay, we will continue. Our first patient is a 60-year-old gentleman who presented following an out-of-hospital cardiac arrest for which he received a DC shock for a VF rhythm, which was noticed by a paramedic who happened to be in the vicinity. The past medical history of this patient revealed that he had an inferior myocardial infarction 10 years ago, which passed uneventful, and for which he had a PCI to the RCA. At the time, he discovered that he is hypertensive and diabetic, and he was already smoker. Through this period, he was on and off smoking. His last follow-up echocardiography revealed an ejection fraction of 48%. His ECG post-DC shock reveals Q waves in the inferior leads with no new ST elevation. His hemodynamics following this cardioversion was stable with no signs of heart failure. His cardiac enzymes was slightly elevated. Bedside echo following that event showed an ejection fraction of 42% with mildly dilated LV dimensions. He showed the old regional motion abnormalities present in the inferior wall, in addition to new regional motion abnormalities in the anterior wall. So, what is the best next step?
So we will give 1 minute. So everyone on the YouTube also will start voting with us, and I will convey the votes to you, Mahmoud and Ahmed.
So I think the majority goes with coronary angiography as the first option in this case. What about the YouTube, Dr. Muhammad Zahran? I think YouTube also vote for coronary angiography.
YouTube is voting for coronary angio 100%.
Okay, this is a clear answer. So, and it is the right answer. Okay, this is clear. From the ACC guidelines of 2015, we should have urgent reperfusion in patients with STEMI who had ventricular arrhythmias. For patients with non-sustained or non-sustained non-STEMI or unstable angina, according to the ACC non-STEMI guidelines, they also should go for coronary revascularization. Even patients with non-STEMI who are not are usually categorized as high risk because they have life-threatening arrhythmias, and these patients should have a coronary angiography within 2 hours of hospital admission, and all these recommendations takes a class 1 recommendation. So the patient had a coronary angiography that revealed a mid-LED lesions of 90%, for which he received a drug-eluting stent. His RCA stent was patent. He had also a non-significant 40% lesion in the distal LCX. However, in the next day, he had a sustained monomorphic VT, for which he had a DC cardioversion. So this is an algorithm for how to manage patients with sustained monomorphic VT. We will go rapidly through it. If there is hemodynamic instability, so direct cardioversion. If he is hemodynamically stable, so we will take a 12-lead ECG. Then consider if there is a substrate as a structural heart disease. If yes, so cardioversion is a class 1. Procainamide can be tried as class 2A, and finally amiodarone or cetalol can be tried as class 2B. This algorithm is from the HA guidelines for VT and prevention of sudden cardiac death. So the next question is this patient indicated for RCD? We have several options. First, he is not indicated. The second option, he was indicated and he should have received an ICD based on his previous myocardial infarction to prevent this event. Second, he wasn't. The third option, he wasn't at an indication for an ICD, but he is now indicated. The last option, he was indicated and he is also now indicated.
Okay, so let's give 1 minute for the YouTubers to vote also, and I will convey the votes to you. So the votes on the Zoom are both indicated previously and currently, while on YouTube I'm getting lots of votes about not indicated. So I think we need an answer to this question with an explanation, please, dear Mahmoud.
Okay, we will go for both indications side by side. First, we will go for the primary prevention algorithm from the HA guidelines for prevention of sudden cardiac death to tackle the previous event of inferior myocardial infarction. So, as we said previously, the patient had an uneventful inferior MI, and the following ejection fraction, follow-up ejection fraction after many years was 40 for 48%. So primary prevention for something like this, if the patient has MI before 40 days, gets sorry. Okay, for primary prevention, we use the criteria of ejection fraction to risk stratify patients who had an indication for ICD. So the first question is when to do that. For patients who had an MI, we do it after 40 days of the MI, and for patients who had revascularization, we do it after 90 days. So the first question, we are far away from that period. So the answer is yes. So the second question is the patient class 1 indication? He had a guideline medical, he should go for guideline directed medical treatment, and we may consider EP study. So the next step is to evaluate the ejection fraction. All the following conditions, we are not in it. The ejection fraction is 48%. So if the ejection fraction is below 30%, we put an ICD even if the NIHA class is 1. Then if the ejection fraction is from 30 to 35, we put an ICD if the NIHA class is from 2 to 3. And if the ejection fraction is below 40, we can, and the patient has non-sustained VT, or we did an EB study and found a sustained monomorphic VT, so he will be qualified for an ICD. If not, so guideline-directed medical treatment. Heart failure, تمام, who had advanced heart failure and who are not candidate for advanced treatments like LVAD or other assisted devices. These patients will not receive an ICD if they are not candidates. If they are candidates, they will receive an ICD with a class 2A indication. So our patient ejection fraction is above 40%, so no ICD for primary prevention. This is the answer for the question: was he indicated for an ICD?
So,
Okay.
Mahmoud, thank you for this nice case. I'd like from you and from Dr. Ahmed Damati to again to summarize the case and focusing if this case is for the primary prevention of sudden cardiac death or secondary prevention. Please, can you do more explanation for the difference between the both term based on this case?
Okay, the case is not finished yet, so let me complete a few slides. Then Dr. Ahmed will give you this summarization. Okay. Can you hear me, Dr. Karim?
Fine, Dr. Mahmoud. Okay.
Okay. So, answering the question for primary prevention, the answer for this question is the left ventricle ejection fraction. If it is above 40%, no indication for an ICD as a primary prevention. The word primary prevention refers to no VT at that time, which is the time before the patient came in this event with this non-STEMI and resuscitated from a sudden cardiac arrest, sudden cardiac arrhythmia. Okay, these patients who had ejection fraction above 40% can also have symptoms that may make them qualified for an EP study with a programmed ventricular stimulation to search for a monomorphic VT. If this programmed ventricular stimulation induced a sustained monomorphic VT, so the patient will be qualified for indication of ICD. So this indication, we do it if he had an unexplained syncope with a classical condition of 2A, and if there is no syncope in the ejection fraction from 35 to 40, we will go with a class 2B recommendation. This is answering from the first question. So for the second question, the patient had an sustained cardiac arrhythmia for which he had a DC shock, but in the first 48 hours from a myocardial infarction, namely here is non-STEMI. So he is not qualified for an indication of ICD for secondary prevention. Secondary prevention means that patients who already get a VT and we want to risk stratify them if they are indicated for ICD. So the patient already get a VF for which he had a DC shock, but this VF occurred in the first 48 hours during an myocardial infarction or non-STEMI, so he is not indicated. The second thing, if this VT comes after this 48 hours, so he will be indicated for an ICD with a class 2A recommendation. Okay, after that, the patient developed 3 more attacks of sustained monomorphic VTs. What would be the next step in management? Okay, this is an algorithm for managing patients with recurrent VTs, and he had for recurrent ventricular arrhythmias. The first important thing is if in the first BCI we didn't do a complete revascularization, so the patient is indicated for another coronary angio and complete this revascularization, as tackling the substrate is the most important thing in patients with ischemic heart disease. The second intervention to do is giving the patient beta blockers. If the patient is stable, it's okay. If he has recurrent VT or VF, we will give him cardioversion. If he DC cardioversion, if repeated attacks, we can use amiodarone, lidocaine, or maybe overdrive basing. Correct electrolytes, check for any reversible causes. If all these measurements fail to stop the attacks of VT, so we will proceed for sedation and arrange for cardiac catheter ablation. Important point in this case, we have a class 3 recommendation against implantation of an ICD in a patient who is indicated for ICD in the setting of recurrent VTs. We should control the VT first and then provide the patient with an ICD. Okay, Dr. Ahmed.
Mahmoud, I would like to thank you about presenting this informative case, and I would like here to add a few more points regarding implantation of ICD in patients with ischemic heart disease, namely those who have previous myocardial infarction. So for a primary prevention indication, classically, those patients who have an ejection fraction that is below 35% are indicated for the implantation of an ICD. The important confusing part is the post-MI period. Classically, those patients who have a myocardial infarction that is recent or myocardial revascularization, so an MI within 40 days or a myocardial revascularization within 3 months do not qualify for an ICD. They do not qualify for an ICD based on data from the Dynamite study and the Cabbage Patch study that did not show mortality benefit on the long run in those patients. The dilemma is that those patients, particularly who have impaired ejection fraction early post-MI, they are not without risk. They definitely are, but they still not indicated for an ICD. So the other piece of the puzzle, which we are missing in our country, is the wearable defibrillator. So an external vest that you give to your patient temporarily that protects him in the vulnerable period till you be able to determine whether he is indicated for an ICD on the long term or not, assessing his ejection fraction after 40 days post-MI and after 3 months post-myocardial revascularization. If his ejection fraction remained impaired, he would qualify for an ICD. If not, he would come out from the ICD indication. Unfortunately, this is not available in our country, so we have to be very cautious in dealing with this group of patients. And the decision of whether to put an ICD or not might be altered in the future based on some data that is emerging, but did not yet change the guidelines, like data from the DAPA study, which showed that early implantation of an ICD in a sub-selected group of patients might be beneficial on the long term. This group of patients are those who had an impaired ejection fraction less than 30%, those who had high Killip class, or those who developed myocardial arrhythmias early post-myocardial infarction. So this is when it comes to the secondary prevention. As for the primary prevention, as for the secondary prevention indication, the bottom line is that all patients who have previous myocardial infarction and developed sustained monomorphic ventricular tachycardia, be it hemodynamically stable or unstable, they would be indicated for an ICD. The confusing part are the ventricular arrhythmia that occur early post-myocardial infarction. So if a patient gets a ventricular fibrillation or ventricular tachycardia second day of his myocardial event, classically, those patients do not qualify for an ICD. But again, we need to bear in mind that those patients might have an increased risk of ventricular arrhythmias down the road more than those who did not. So we have to take this cautiously with a grain of salt, and each patient has to be treated individually according to his clinical scenario. An important bit that would change the decision if your patient gets a sustained monomorphic ventricular tachycardia. A sustained monomorphic ventricular tachycardia is notorious to being scar related, and scar related ventricular tachycardias tend to recur regardless the acute myocardial event. And that's all. Thank you so much.
Okay. We will proceed.
Thank you so much, Ahmed and Mahmoud. We have a couple of questions and comments related to this case. The first comment from Dr. Karim Saeed. I think Ahmed, you mentioned this comment that monomorphic VT is unlikely to be due to ischemia, and likely there is a fixed substrate that is not going to be disappear by revascularization. So I think Ahmed, you agree to that.
Yes, absolutely, Dr. Karim. I think we have to individualize our decision according to the clinical scenario, bearing in mind this observation. If a patient gets sustained monomorphic VT, even if this occurred 24 hours after his myocardial event, I'd be very cautious to discharge him without a defibrillator. Unfortunately, data is not clear in this area. We know that the risk is high. Up till now, the classic indication is not to put a defibrillator, but again, those patients has to be treated individually according to each patient clinical scenario.
Thank you, Dr. Ahmed. And we have another question from Dr. Ahmed Ragab related to the recurrent ischemic episode. If the patient got VF during the intervention for primary PCI, for example, and then after a week, he gets a stent thrombosis, and during intervention, he gets another VF, and the ejection fraction is 50%. Is ICD indicated in this scenario?
I think, again, this is one scenario that is tough to decide. You can look at it from either ways. You can say that this second event is a new myocardial event, and you can pass it as a primary ventricular fibrillation and refrain from putting the device. But you would think that this patient is at a high risk of future events. Likely his propensity to the occurrence of ventricular arrhythmias is very high. So I guess we have no clear answer based on literature and guidelines, but my personal preference would be putting a defibrillator for this patient, particularly if he does have any other risk factors, like an impaired ejection fraction, or like incomplete revascularization perhaps. That would be my take on it.
Okay, thank you so much, Ahmed. So I think we can continue right now. I believe you will go to the second case.
Okay. We have a 22-year-old gentleman who presented for evaluation of the presence of a BVCs during a routine ECG. He is totally asymptomatic. The ECG revealed an RVOT BVCs with no other abnormality. His echo revealed no other abnormalities. His Holter revealed 1,500 BVCs of the same morphology, no couplets, triplets, or non-sustained VT. He careful history taking revealed an unexplained sudden cardiac death at the age of 33 in one of his cousins. So, what is the best next step?
So I ask the Zoom and YouTube to respond to this question. Maybe Mahmoud, you can summarize it again while waiting for the results of voting.
Okay, we have a patient with asymptomatic BVCs. Apparently, he has no other risk factor regarding structural heart disease, normal echo, normal baseline ACG. The frequency of these BVCs is not that high, only 1,500 BVCs. However, he has a family history of sudden cardiac death that is considered relevant. So, asymptomatic BVCs, no apparent underlying structural heart disease, positive family history of sudden cardiac death.
So we'll give 1 minute for all participants to share their opinion. So Mahmoud, I think we have a 100% response regarding the cardiac magnetic resonance for evaluation of this case. So what do you think?
Okay, this is the right answer. So we will proceed with from this position paper for patients who has asymptomatic published by the European Society of Cardiology. Asymptomatic with BVCs more than 500 in a 24-hour holter, these patients should be referred to a specialist with further evaluation to rule out any underlying structural heart disease, ischemic. Although BVCs who are asymptomatic in a relatively low number are not considered dangerous or are not alarming, this phrase will be right only after we exclude any underlying structural heart disease. If we discovered any underlying structural heart disease, so the story will change. Okay, this is the slide from the same paper that refers to when what is the criteria or the description of BVC that should that will divert your attention that this patient might have a worse prognosis. So first of all, any underlying structural disease. Second, BVCs in the holter with frequency more than 2,000 per 24 hour. Third, complex BVCs in the form of couplets, triplets, or non-sustained VT. More than one morphology. The BVCs increase with exercise. BVCs from non-outflow tract, which is the site that we usually refer to as a benign BVC. BVCs with short coupling interval that cause RMT and may induce torsade de poids or torsade de point. Finally, BVCs with a very broad QRS complex, which are usually related to cardiomyopathy. Looking at these criteria, the patient had none of them. His cardiac MRI examination revealed no abnormality. So follow up and he is asymptomatic, so just follow up, not even medical treatment. 2 years later, the patient presented now with frequent palpitations that is exacerbated during exercise. ECG revealed the same RVOT BVCs with no other abnormality. The echo revealed just mild dilatation in the right ventricle with no other abnormality. The Holter revealed 8,000 BVCs with two predominant morphologies, short nuns of non-sustained VT. Semi-Ardan at this time was suggestive of ARVC, arrhythmogenic right ventricular cardiomyopathy. Okay, we'll talk through this HRS expert consensus on the management and the risk stratification and treatment of patient with arrhythmogenic cardiomyopathy. This term refers to all forms of cardiomyopathy that doesn't include an ischemic or valvular underlying valvular abnormality, which refers to ARVC, the ALVC, LV non-convection, and some other forms. There is a modifying task force criteria for the diagnosis of ARVC, which was published in 2010. From this criteria, the patient has a definite diagnosis of ARVC. So what is the next step to do? Is this patient indicated now for RCD or not?
So
Patient,
we
okay.
let's respond to this nice case. We have this patient with very frequent PVCs, and now the condition changed, and he has arrhythmogenic right ventricular cardiomyopathy. So is ICD indicated or not? I think we have controversy regarding this question, Mahmoud. We have some answers with yes and some answers with no. So, what do you think is about the ICD for this patient?
Okay, we will proceed with the indications step by step. This is the algorithm suggested by this consensus paper. The worrisome, so we will divide it. So first, patient with arrhythmogenic cardiomyopathy, which is a broader term, as I said, that includes patient with RVC and other types of genetic arrhythmogenic cardiomyopathy. As dynamically unstable VT, the indication for ICD will be clear, which is not the case in this patient. The next step, if the patient has a sustained, well-tolerated VT, the indication will be class 1 for arrhythmogenic cardiomyopathy other than ARVC, and will be 2A for patient with ARVC. The third step, if the patient has a syncope that is suspected to be from an arrhythmic origin, the indication of ICD in this group will be 2A for all arrhythmic cardiomyopathies. Okay, the second step is the LV ejection fraction. If it is below 35 with NIHA class 2 to 3 symptoms, indication is class 1. If it is below 35 again and the NIHA class was 1, the indication is 2A. So what is the third step? There is a scoring system that consists of major and minor criteria to risk stratify these patients. For 2A indication for ICD, we have to had a 3 major criteria, 2 major and 2 minor, or 1 major and 4 minor. And 2B criteria have a less strict definition. So what is the major criteria? First, non-sustained VT. It is present in the patient. The second, inducibility of VT in an EBS, which will should be considered. We didn't. Later the patient did an EB study and he had a sustained morphic VT, and finally a left ventricular fraction below 49, and which was not the case. So he has two major criteria. From the minor criteria, male sex, this is a one minor criteria, and the BVC count in the Holter more than 1,000 in a 24-hour. This is the second uh, minor criteria. So he has two major and two minor criteria which makes him indicated for an ICD with a class 2A indication. Okay, the second slide to share is the decision about catheter ablation in patients with ARVC. First, if he had a sustained monomorphic VT, we can directly proceed to a catheter ablation procedure with a class 2B indication. For a class 2A indication, the patient must try medical treatment first, and if medical treatment is not effective or not tolerated, including amiodarone, and patient has only a non-sustained VT in the halter or a high burden of BVCs. So first, medical treatment, beta blockers, and then escalate medical treatment and amiodarone and other treatment. If this medical treatment is not effective or cannot be tolerated, so we will proceed to an ablation procedure. This table will summarize the indications for ICD and the role of risk stratification in these patients. So VT stable, class 2 indication in RBC, class 1 indication in arrhythmogenic cardiomyopathies. If the patient had syncope, class 2A in both diseases. If the patient had an ejection fraction below 35, class 1 indication. If NIHA class 2 or 3, class 2A indication. If the NIHA class is only 1, there are some certain subtypes in the arrhythmogenic cardiomyopathies that have specific indication for ICD in the area of ejection fraction from 35 and 45. This indication is 2A. Finally, the scoring system that we just described, 2A and 2B. And finally, the role of EAP study in patients in risk stratification of patients of ARVC who do not meet the previously mentioned criteria is just 2B. The final word about ARVC patients, that competitive sports are class 3 been harmful, are not indicated at all for patients with ARVC, both for the arrhythmic point of view and for the progression of the disease. Okay, Dr. Ahmed will share us with some comments about this case.
All right. So I thank again Dr. Mahmoud for presenting this case. I would like to comment on the presentation of syncope in patients with ARVC, and this would extrapolate to all other patients with non-ischemic cardiomyopathy. We need to know that syncope is an ominous sign as a presentation for patients with the non-ischemic cardiomyopathy. And the problem does not only lies with the fact that syncope carries a poor prognosis, but it also lies in the fact that a lot or virtually all our investigative tools are limited by low positive as well as negative predictive value. And this would go up to the invasive EP study as well. So in patients with non-ischemic cardiomyopathy, you might get a negative EP study and the patient would have a syncope because of an arrhythmic substrate that caused at some point transient ventricular fibrillation or ventricular tachycardia. That's why frequently the only thing that you have to depend on is the history. So if you get an arrhythmic sounding history, which means that this patient does not have a prodrome and there is no etiology for his syncope, he passed out while he was sitting or lying down, and there is no post syncope weakness or fatigability, all these factors would point to an arrhythmic etiology for the syncope and has to be taken seriously. And frequently, the only answer in those patients would be implantation of an ICD. This, of course, varies according to substrate and has to be taken cautiously. But again, the message is you should not pass any patients with non-ischemic cardiomyopathy who is presenting with syncope unless you fully investigate him and you make sure that this syncope was not a transient, potentially lethal ventricular arrhythmia. That's all. Thank you.
Okay. The following few slides, we will go we will go through the different types of cardiomyopathies, rapidly summarize the indications of ICD in these categories. First, patients with okay. First, we will proceed with patients with non-ischemic cardiomyopathy. First, I would like to shed a light on the role of cardiac MI in the diagnosis, class 1, and risk assessment of sudden cardiac death, class 2A, in patients with non-ischemic cardiomyopathy. The second thing is the role of genetic counseling and testing in patients with diabetic cardiomyopathy, which has a class 2A recommendations in certain situations when the patient develop conduction system disease or develop LV dysfunction below the age of 40 years or have a positive family history of sudden cardiac death and non-ischemic cardiomyopathy. The second thing is to go through this algorithm from the HA guidelines for VT and prevention of sudden cardiac death regarding primary prevention. So, as usual, if the patient has a sustained VT or a sudden cardiac arrhythmia survivor, the patient will be had an will take a class 1 recommendation for an ICD. The second thing, if the patient has symptoms suggestive of ventricular arrhythmias like syncope. So we have two options: either go directly to an ICD or risk stratify the patient with an EV study, with both having the class 2A recommendation. So then, if the patient has an ejection fraction below 35 with 9 class 4, 2 to 3, so he will be indicated for an ICD with a class 1 recommendation. Finally, certain subtypes of non-ischemic cardiomyopathy, like lamin. Okay, anyone is seeing anything? Okay, I will continue. Certain subtypes of non-ischemic cardiomyopathy, like lamina A mutations, will be indicated with two risk factors, will be indicated directly for an ICD, even if the ejection fraction above 35 with a class 2A recommendation. And then we will add them to the same table to make a comparison at the last thing to comment on patient with non-ischemic cardiomyopathy is susceptibility for this will be taken from this paper for patients for athletic patients with cardiomyopathy. So if the patient had several characters, he will not be advised for exercise at all, competitive exercise. If he has symptoms, ejection fraction below 40, the CMR shows extensive fibrosis, more than 20%. He has frequent ectopes and non-sustained VTs in the halter or during exercise testing. And finally, if he has unexplained syncope. Also, if he has several subtypes from familial diabetic cardiomyopathy or he has a family history of sudden cardiac death. While those who are asymptomatic, who had no unexplained syncope and no frequent arrhythmias in monitoring or exercise can be allowed to do exercise if the ejection fraction is above 40%. The next category of cardiomyopathy is hypertrophic cardiomyopathy. We will not go in depth through this type of cardiomyopathy because it is covered in another webinar. Here we will shed a light on several items. First degree relatives of patients of hypertrophic cardiomyopathy due to a known causative mutation, a class 1 recommendation for genetic counseling, a patient who are clinically suspected or diagnosed with hypertrophic cardiomyopathy, genetic counseling and genetic testing is 2A. Finally, class 3 recommendation for patients with an unidentified hypertrophic cardiomyopathy genotype, but they do not have any risk factor of sudden cardiac death. In patients with hypertrophic cardiomyopathy, it is very important, and they have a class 1 recommendation is to use the scoring system. In patients with hypertrophic cardiomyopathy who have syncope, ICD implantation takes a class 2A recommendation. In patients with hypertrophic cardiomyopathy, EP study for risk stratification is not recommended, class 3 recommendation. Finally, competitive sport in patients with hypertrophic cardiomyopathy, we'll comment on it through this figure. If the patient has one of these six high risk criteria, abortion, cardiac death, syncope, exercise-induced ventricular arrhythmias, abnormal pressure response to exercise, high risk score, or gradient above 50, he is not allowed to participate in competitive sport. Next are patients with adult congenital heart disease. The cornerstone in these patients is to evaluate and treat any residual anatomic abnormalities. Even if the patient had a ventricular arrhythmia, the role of evaluation and treatment of this residual anatomic abnormalities is prior to implanting an ICD or doing an ablation procedure. And this is an algorithm from the HA guidelines. We'll go to directly to the table. So if the patient has a sustained cardiac arrest, the indication is clear, class 1 recommendation. Stable VT takes a class 2A recommendation. Syncope, class 2A recommendation. If the patient has an ejection fraction below 35, regardless to the grade of NIHA symptoms, he takes an ICD for a class 2B recommendation. So, if a patient has syncope or high-risk features, he would be qualified for an EB study with a class 2A recommendation. Finally, in patients with other congenital heart disease who have asymptomatic ventricular arrhythmias, prophylactic antiarrhythmic therapy with class 1C medications or amiodarone is contraindicated class 3. An important point, a patient who has a residual anatomical abnormality, tackling this abnormality should be done prior to consideration of ablation or an ICD. Okay, some more cardiomyopathies, cardiac sarcoidosis. This is an algorithm from the HA guidelines. As usual, patients who have survived a sudden cardiac arrest or sustained VT, whether spontaneous or inducible, will get an ICD. Ejection fraction below 35%, he gets an ICD, also class 1 recommendation. Patient who has an ejection fraction above 35 and had syncope or extensive scar in MRI or are indicated for a permanent pacemaker have both options, go directly to ICD class 2A or do first an EP study. If there is a sustained monomorphic VT, the patient will be qualified for an ICD. Finally, immunosuppression has a class 2A recommendation of both improving the underlying disease and preventing recurrent ventricular arrhythmias. Okay, and it is also added to the table. Finally, amyloidosis. There is a specific indication for patient with AL type amyloidosis and has an unsustained Vitizen Holter. An ICD will be indicated with a class 2B recommendation. Dr. Ahmed.
I really want you guys to have a close look at this slide that Dr. Mahmoud nicely put together. I would like you to look at it in columns rather than in rows. So regardless the type of the structural heart disease that you are facing, if your patient developed an aborted sudden cardiac death episode or came in with stable ventricular tachycardia or presented with syncope, he would pretty much be indicated for an ICD with a variable degree of evidence. If you look at column 4 and 5, you would see if your patient is getting in without an arrhythmic episode but he has an impaired ejection fraction regardless his baseline structural heart disease. He still would be indicated for an ICD if his NYHA class 2 or 3. If he is NYHA class 1, the level of evidence would be less. And this is because data from the SCUD-HIFT study and data particularly from the SCUD-HIFT study, is the data that dictates this guidelines in patients with non-ischemic cardiomyopathy. And this data is extrapolated to other types of cardiomyopathy that we do not have strong evidence for. It's also worth mentioning, if you have a quick look at the last two columns, that competitive sports are virtually contraindicated in all types of substrates. And the role of EP study is very low. It can sometimes be contraindicated, like in patients presenting with a substrate of hypertrophic cardiomyopathy, and it can have a minor role in other substrates. And that's all. We are open for your questions.
Yes,
Thank you,
Ahmed.
Mahmoud.
Yes.
Let's take a break, and I think we have a nice question from YouTube, Dr. Muhammad Zahran.
Yes, please. I'm really amazed by this nice presentation, and I'm really attracted to the way you are presenting. It's very nice. The data is very clear and very easy now since this slide is in front of our eyes. But actually, we have a pediatric surgeon from Cardiff, UK, Professor Ilham. She's with us, and she asked me a question because they are facing those kind of pediatric population, maybe in a younger age group, and those guys are presented sometimes by sudden infant death and sudden cardiac death within the pediatric population, whether during exercise or whether during rest or sleep, even sudden infantile death during sleep. So maybe we can take like a 3 to 4 minutes resume about this question, and if they have a specific recommendations during performing a non-cardiac surgery regarding their anesthesia and surgical procedure. Thank you so much, Ahmed.
Thank you. Very important questions. I would like to thank you for that. The pediatric group is really a particular group of patients that that needs to be looked at it very cautiously, because the decision of implanting a defibrillator in this group of patients is not easy. It's definitely limited by several factors, namely the frequent inappropriate shocks that this population gets because of the fast basal heart rate and the high exercise heart rate, as well as the expected gross, which limits the implantation of the ICDs and dictates frequent battery changes and lead changes that carries the risk of infection and extraction and so on. So in this group, we are very cautious about implanting the ICDs, and those patients who presents with arrhythmias, they have to be investigated cautiously to reach the primary etiology. You have to investigate them in the line of structural heart disease up to the need for an MRI, and you have to investigate them in terms of the channelopathies. And there is a protocol for dealing with these patients that was published years ago in a CASPER study, where you look for the substrate of arrhythmia, even if it's not clear. You do an epinephrine challenge and you do an EP study, and you might need to give the patients class 1C sodium channel blockers to be able to expose a latent Brugada syndrome. And they have to be treated according to their risk. But you have to bear in mind that you have to use all the medical treatment possible without putting them in the risk of putting an ICD. For example, if this patient has a latent long QT syndrome that is causing the premature family history of sudden cardiac death or causing him to get a syncopal episodes, he has to be on the maximal tolerated doses of beta blockers. This applies as well for patients who presents with syncope and family history of sudden cardiac death, and they have a CPVT. So the point is the diagnosis is crucial to be able to guide you in the proper management pathway. The problem is this diagnosis might not be easy. It might require invasive testing, and you unfortunately might reach to a blind alley where you are just facing a patient with family history of sudden cardiac death and presenting with syncope, and all what you have is the diagnosis of idiopathic presumable ventricular arrhythmia. At that point, you might be obliged to put an ICD. So this is for the
Yes.
first question. Um, you
The
mentioned
second
something
question regarding the anesthesia and preoperative assessment for non-cardiac surgery.
for which group of patient?
The pediatrics also, the same group of patients that we were discussing.
Well, again, يعني this is be a wide spectrum of disease. The patient has to be, the decision has to be individualized according to the substrate that the patient is having and his clinical presentation, whether he is presenting with syncope or true ventricular arrhythmias that is documented, or just long QT, or just another arrhythmic substrate. But generally speaking, if the patient does not have cardiac arrhythmia, which is the active cardiac condition that present in this etiology, in this group of patients, they could easily be anesthetized and go to surgery, uh, uh, provided that they are clinically stable and again based on their presentation and substrate.
Thank you so much, dear Ahmed. So to wrap up this issue, it goes the same like the adult population. If it is arrhythmic, you may end up with, as you said, a blind tunnel ending up with the pacing technique. If it is not arrhythmic, then it is structural. It's depending upon the substrate. Accordingly, also, if you get the patient in an accident or something or a sports injury that like a fracture tibia or a fracture femur or a retroperitoneal hematoma during playing football or something like this, and you need to perform an anesthesia to perform a surgical procedure, then it depends whether it's arrhythmogenic, and then in this case we need to discuss with the anesthetist the arrhythmogenic agents that are used during anesthesia and to avoid certain agents. I understand from what you said that there is no role for prophylactic amiodarone infusion or something like this. This is not on the table at all, because actually it may induce arrhythmias and make the situation a little bit more complicated. And if you have a structural heart disease, then you will follow according to the structural heart disease substrate. Thank you so much for this comprehensive answer, Dr. Ahmed Al-Damati, and I will pass the mic now to Dr. Karim Mahmoud to continue the Zoom and YouTube questions.
Thank you, Mohammed and Ahmed. We have a couple of questions from the Zoom. A question from Professor Dr. Hatem Al-Sukkari regarding this nice case that Mahmoud presented. Regarding that the CMR was normal before 2 years. What is the role of the exercise ECG or a prophylactic beta blocker in this type of patient?
Okay, thanks, Dr. Hatem. Thanks, Dr. Mahmoud. If I understand you right, we are asking about the role of beta blockers in the management of PVCs with an ARVC substrate. Am I correct?
Dr. Hatem is asking about that the CMR is normal and the patient is complaining of frequent PVCs. And he asking about the rule of two items: the exercise ECG for evaluating this patient, and the rule of prophylactic beta blocker for treating or for reducing the burden of the PVCs in these patients?
Okay, so definitely they both do have a role, but when we'll talk about the exercise ECG first, if your patient is presenting with exercise-induced palpitations or exercise-induced symptoms, the stress ECG would have a very important diagnostic role. So frequently we get patients who are experiencing palpitations with exercise, and you do everything and it turns out to be negative. An important way to provoke this arrhythmia without doing an invasive study is to imitate the situation where he gets his symptoms. So so definitely exercise test would have a diagnostic role. I'm not sure that it does have a prognostic role in this category of patient, particularly if their heart is normal in an echo and an MRI. The other thing is, that we might resort to an exercise test before doing an EP study is to know whether you would be able to induce this arrhythmia in the EP lab or not. Some of this outflow tract ventricular arrhythmias, which is the commonest, can be induced with the adrenaline surge. So if you get it with exercise, you know that if you give your patient isoprenalin or adrenaline in the EP lab, you would be able to induce his arrhythmia and therefore be able to treat it. But if this cannot be achieved in an exercise test, you are unlikely to be able to provoke his arrhythmia with isoproterenol or adrenaline. That's why you might not be able to induce it in the EP lab, and thus you will not be able to fix it with ablation. The other question was about beta blockers. From our clinical practice, regular beta blockers are not very effective in controlling premature ventricular contractions. On the other hand, beta blocker that does have antiarrhythmic properties like sotalol are effective. Other drugs that we frequently use are calcium channel blockers. This is as a first line therapy, either beta blocker with antiarrhythmic function or calcium channel blockers. And if we can't get the situation under control with these, we resort to class 1C antiarrhythmics like flecainide, and we leave stronger medications with well-known side effects like amiodarone to resistant cases and those cases with cardiomyopathies, PVC-induced cardiomyopathies that cannot be fixed with an ablation, or the patient does not prefer ablation, or there is another obstacle, social or financial, that prevent getting the patient to the EP lab. I hope that answers your question. Dr. Karim, can you hear us? We're not getting any voice signal from you guys. Can you hear us?
Dr. Ahmed, do you hear me now? Sorry.
I hear you now, yes.
We have a comment from Professor Dr. Karim Saeed regarding your case and regarding the importance of electrophysiological study in risk stratifying your patient. Do you have a comment regarding the importance of the EB study in this category of patient?
So Dr. Karim Saeed will comment, or are we asked to comment on this subject?
No, Ahmed, please comment. Ahmed?
Yes, I'm hearing you, Karim. Again, EP study has a limited role in risk stratification of this particular population of patients, namely patients with non-ischemic cardiomyopathy, be it dilated cardiomyopathy, hypertrophic, or ARVC. Its role is inferior to its definite role in ischemic cardiomyopathy. And the reason is in patients with ischemic cardiomyopathy, they have a scar that is frequently transmural. So if you get the patient to the EP lab and you induce ventricular arrhythmia, it means that his scar is arrhythmogenic. If you don't get ventricular arrhythmia, you're probably dealing with a benign scar from the arrhythmogenic standpoint. The situation is different when you are dealing with patients with non-ischemic cardiomyopathy, because some of them do not have a scar and some of them have at most minimal scar. So you can frequently get a negative EP study and the patient is still at a risk of developing ventricular arrhythmia. That means that the negative predictive value of an EP study in patients with non-ischemic cardiomyopathy is limited. It's almost contraindicated to do an EP study for some categories of patients, like hypertrophic cardiomyopathy. It has some role in dealing with non-ischemic cardiomyopathy patients and patients with ARVC. But generally speaking, its role is inferior and is limited by a low negative predictive value.
Thank you, Ahmed. We have two more nice questions from dear friend Dr. Ahmed Rajab. The first one regarding the definition of frequent PVCs during the 24-hour. What is the different definition? And the second question regarding if you consider a cousin is a relevant family history member for sudden cardiac death?
Okay, again, thanks, Ahmed, for the nice questions. I personally consider that I use the method that consider the percentage when we are dealing with PVCs in a Holter model. So in my mind, any percentage that is less than 10% of the total heart rate, this is considered a small burden. In percentages that range between 10 to 20%, this is considered a moderate burden. And in patients who have 20% or more PVCs in their Holter monitor, I consider those patients a heavy burden of PVCs. And this is a classification that is based on the association between PVCs and the risk of developing PVC-induced cardiomyopathy. So in patients who have a high burden, namely more than 20% of the total heartbeats, these patients are at risk of developing PVC-induced cardiomyopathy. Those who have a percentage less than 10% does not have a risk of developing PVC-induced cardiomyopathy. And the interval in between is a gray zone where the risk is possible. So this is the classification that I adopt because of the fact that it has some correlation with the risk of developing PVC-induced cardiomyopathy. Sorry, I forgot your second question.
The second question about the cousin. Do you consider a cousin, if you have an event in a cousin, you consider it a significant family history or not, of a sudden cardiac death, of course?
Well, of course, first degree relatives are those what really matters. So the death of a cousin is considered a far relative, and it will not certainly bring up a red flag to my attention, but again, it might raise a yellow flag.
So thank you, Ahmed, for these nice comments. I pass the mic again to you and Mahmoud for continuing this nice discussion.
Thanks, Dr. Karim.
Thank you, Dr. Karim. So we will proceed with the third scenario. We have a 18-year-old boy who is trying to start a career as a tennis player. He experienced palpitation during exercise and he had two attacks of pre-syncope. His ECG at baseline shows no abnormality, echo completely normal, sorry. His Holter monitoring was unremarkable, and his family history is positive for a second degree relative. As Dr. Ahmed said, it is only a yellow flag. So, what is the best next step?
So again, I asked all the participants to respond to this nice scenario. And again, while responding, I'll ask you, Mahmoud, to summarize this case in a few words.
Okay, this is a 18 years old boy who has some sort of palpitation related to an arrhythmia, and it is related to exercise. His baseline workup revealed no abnormality regarding echo. So, what is the question? More imaging like CMR or exercise testing, or just extended monitoring, or a CT coronary angio.
So, so Mahmoud, most of the answer from Zoom and YouTube goes for exercise testing of this patient.
Which is the right answer. We did an exercise testing for this patient, and he developed a bidirectional VT. So this is a recommendation from the American Heart Association guidelines for VT and prevention of sudden cardiac death, and it says that for patients who are suspected for a CPVT or an underlying ischemic heart disease, it is a class 1 recommendation to do exercise testing to provoke or induce such arrhythmia. So we have a bidirectional VT. What is the next step?
So your next question is regarding the management or the initial management of this type of arrhythmia, and I'll ask all the participants to respond to this question.
Hello, Dr. Jeremy. How are you? It's a pleasure to meet you.
So Mahmoud, again, most of answers or all 100% of the answer goes for beta blocker for this patient.
Okay, which is the right answer. So, um, yeah, okay. For a diagnosis of a patient of a CPVT, we have to have to show the presence of a structure normal heart, normal baseline ECG, and a bidirectional or a polymorphic VT that is induced by exercise or emotions. This takes a class 1 recommendation. The other recommendation, if the patient just have the pathogenic mutation. Okay. Management of patient of CPVT. The first step is beta blockers, which takes a recommendation of class 1 recommendation. Even patients who have the genetic abnormality but doesn't show the phenotype or the ventricular arrhythmias or have a negative exercise testing, these patients would also be qualified for beta blockers with a class 2A recommendation. If beta blockers after maximizing the dose cannot control his symptoms, the other option is flecainide, which takes a class 2A recommendation. Flecainide would be used also for patients who are qualified for an ICD and receive recurrent shocks. For ICD for those patients, the ICD indication is for those who are on beta blockers with or without flecainide and they still have symptoms of related to recurrent attacks of VT or recurrent syncope or patients who survived from a sudden cardiac arrest. The role of EBS in patients with CPVT is totally contraindicated. Finally, left cardiac sympathetic denervation could be helpful with a class 2B recommendation for those patients who were refractory for all the previous measurements. So this is our table again. If the patient survived sudden cardiac arrest, he takes an ICD as a class 1 recommendation. If he gets syncope after maximization of the medical treatment in the form of beta blockers, he will be qualified for an ICD with a class 1 recommendations. Beta blockers is indicated with a class 1 recommendation for all patients with CVT and with patients with the class 2A recommendation for patients who have the genotype but not the phenotype. Other drugs like flecainide has a class 2A recommendation. Left sympathetic denervation have a class 2B recommendation. Genetic testing in the first degree relatives has a class 2A recommendation. Finally, EPS has a class 3 recommendation, and competitive sports in patients with CPVT is completely contraindicated. So in the following slides, we will rapidly review the other forms of channelopathies and put them to our table. First, we will talk about Brugada syndrome. For a diagnosis of Brugada syndrome, it is limited to the type 1 Brugada pattern with an ST elevation of 2 or more millimeters in one or more leads in the right precordial leads positioned in the second and third and fourth intercostal spaces, which is occurring spontaneously or after drug provocation for other patterns like type 2 and type 3 with sodium channel blockers. This is a suggested algorithm for dealing with patients with suspected or documented Brugada pattern if there is a spontaneous type 1 genotyping is a class 2A and genetic counseling for the first degree relatives is class 1. If the patient shows suspected Brugada syndrome, type 2 or type 3 patterns, a pharmacological challenge would be indicated with a class 2A recommendation if it provoked a spontaneous type 1 Brugada ECG pattern. So we are in the same line. If the patient gets cardiac arrest or survived a sudden cardiac arrhythmia or gets unexplained syncope, so he will be indicated for an ICD. If he is not qualified, indicated for ICD for other reasons like life expectancy or refusing or ICD is not available, so we can proceed to quinidine or catheter ablation. Which will be the same case if he get an ICD and then he had recurrent attacks with VT and received multiple shocks. If the patient doesn't have ventricular arrhythmias or didn't or an unexplained syncope, so a risk stratification with an EP study may be suggested with a class 2B recommendation. Patients with Brugada syndrome should avoid drugs that cause ST elevation in the right precordial lead, should treat fever promptly with antibiotic drugs, avoid excessive alcohol intake and cocaine and big meals. So the data related to Brugada syndrome will be added to the table. We can appreciate here that the indication for ICD is class 1 in HCA guidelines, while it is class 2A in ACC guidelines, and is the same for the use of quinidine in such patients. Genetic testing in patients with Brugada takes a class 2B recommendation. EBS for risk stratification of patients with Brugada who are not qualified for an ICD takes a class 2B recommendation. The following channelopathy is congenital long QT syndrome. Here is the definition of long QT syndrome from the ACC guidelines, which define it if the corrected QT is above 480 in repeated 12 lead ECG, or the score is above 3. Also, if the patient has a genetic mutation, irrespective of his QT duration, he had the diagnosis of long QT syndrome. Also, the diagnosis of long QT syndrome can be considered in patient who is presented of QT above 460 in repeated ECGs, but this patient has unexplained attacks of syncope with no other causes that can cause QT prolongation, and this definition takes a class 2A recommendation. So this is an algorithm also for dealing with patients with long QT syndrome from the HA guidelines. As usual, if the patient resuscitated from a cardiac arrest, he received an ICD, but we should take care here that beta blocker should be initiated first. The second thing is that in this algorithm, that the definition of QT, correct QT in patients with long QT syndromes in the HA guidelines is 470. So beta blocker will be indicated as class 1 if we are longer than this number, class 2A if we are below this number. If the patient has symptoms or has a high risk criteria, medical treatment should be intensified. The second thing, ICD could be indicated if this treatment couldn't control the patient's symptoms. In asymptomatic patients who have a QTC above 500 milliseconds, the same treatment options can be used, but with a low recommendation of 2B. So the language QT data was added to the table. We see here in syncope, we have two indications, 2A and 2B, beta blockers, depending on the QTC, if it is above 470 class 1, below 8 2A. However, the ACC guidelines indicate that beta blockers class 1. We can use sodium channel blockers like mixilitine and flecainide in patients with long QT type 3 if the corrected QT is above 500 with a level of evidence of 2B. Left sympathetic denervation in patient with long QT after failure of other measures takes class 1 or 2B in the HA guidelines, and takes 2A in the ACC guidelines. Genetic testing is class 1 in patients with long QT. We have also special situations like drugs that cause prolongation of QT, correction of electrolyte imbalance like hypomagnesemia, hypokalemia, hypocalcemia, and specific situations like avoidance of swimming in patients with long QT type 1, and loud noise in patients with long QT type 2. And finally, the role of ABS in patients with long QT is contraindicated, class 3 recommendation. The last one in the channelopathies is congenital short QT syndrome. Class 1 recommendation if the correct QT is below 340. 2A recommendation if the correct QT is below 360 with one of the following. A pathogenic mutation is confirmed, family history of short QT syndrome, family history of sudden cardiac death below the age of 40, or survival from a VT or VF episode in absence of a structural heart disease. Also, the data from the short QT is added to the table. Aborted sudden cardiac death, as usual, takes a class 1 recommendation. Syncope in a short QT syndrome takes a class 2B recommendation for ICD, but this recommendation is from the HA guidelines of syncope, not mentioned in the other guidelines. We used it from the beginning of the study, from this presentation. Quinidine could be used with a class 2A recommendation in those patients. Quinidine and sotalol could be used with a class recommendation of only 2B in patients with short QT syndrome. The first is from the HE guidelines, and the second from the SC guidelines for patients who didn't receive an ICD and has a family history of sudden cardiac death. Genetic testing in short QT syndrome is to be no role of EBS in those patients. This is a recommendation for early revalorization pattern syndromes from the HA guidelines. Those patients who are asymptomatic and presenting this pattern in ECG, only observation without treatment is a class 1 recommendation. For those who survived sudden cardiac arrest or sustained ventricular arrhythmias, they are qualified for an ICD with a class 1 recommendation. Genetic testing in patients with early revalorization pattern is class 3 recommendation. It is contraindicated. There is another indication for ICD in those patients, in patients who are suspected for arrhythmic syncope in presence of family history of a combination of early polarization pattern and cardiac arrest. If there is this family history, ICD may be considered with a class 2B recommendation. EBS has no role in such patients. Okay, so Dr. Ahmed will comment on this slide.
Okay, so before commenting on this slide, I would like to touch up on the case very quickly and remind you that in patients with the CPVT, you have to be very careful in rushing for a defibrillator because this arrhythmia is notorious to be triggered by exercise and by emotional stress. So if your patient gets inappropriate shock for sinus tachycardia, this would trigger an adrenaline surge that would cause more sinus tachycardia, and eventually it might trigger VT stall. So our routine is to treat these patients with beta blockers to the maximum tolerated dose and to follow them with an exercise stress test every 3 months to make sure that there is no inducible ventricular arrhythmia. And then I would like to touch up again on this figure that or table that Mahmoud nicely put together, and I would like you again to look at it vertically instead of looking at it horizontally. So if your patient who has channelopathy, be it CPVT or Brugada syndrome or long QT, who presented with an aborted sudden cardiac death episode or syncope, he probably will end up getting an ICD regardless the level of evidence. The mainstay of treatment of CPVT and long QT is beta blockers. You might resort to other medications in some other conditions like flecainide in long QT3 or flecainide in patients with resistant ventricular arrhythmias with long QT, or in quinidine or sotalol in patients with long QT and Brugada syndrome. Again, the role of EP study is almost nil in channelopathies, except for perhaps a possible role for risk stratification and catheter ablation in Brugada syndrome, which is turning out to be a sort of a cardiomyopathy rather than a channelopathy, with the scar being noted in the free wall of the right ventricle and in the right ventricular outflow tract. Competitive sport is very important to be avoided in patients with CPVT, and those patients with Brugada syndrome and long QT have to have some lifestyle modification techniques in terms of avoiding the drugs that would precipitate either condition, or avoiding fever in cases of Brugada syndrome, avoiding headache in cases of Brugada syndrome. And that would be it, and we are happy to take your questions.
Thank you so much, Ahmed. I like these homemade tables, and it's a privilege to have them on CEC. Really, it's very nice. So we have some questions from our audience. Dr. Rehab Hamdi has two questions. The first one regarding if there is any experience about using probafenone as a challenge test to unmask Borgata type 1?
Okay, thanks, Karim, for this question. What we usually do is use intravenous procainamide, and in the West, Europe, and in the US, they use intravenous agnaline to provoke latent forms of Brugada syndrome. Um, I think that using oral propafenone in this setting is hazardous because we are not aware of the dose, and we are not aware of the latent effect of propafenone. We're not aware how much we need to keep the patient in hospital, whether he will develop ventricular arrhythmias few hours after leaving the hospital. That's why I do refrain from using this technique in those patients.
Thank you, Ahmed. The second question regarding again the long QT syndrome. Can we rely on long QT detected by Holter? And what about the cutoff value in this case?
We really don't. We resort to a 12-lead electrocardiogram to be able to do the right correction using the usual formulas. We do not depend on QT intervals edited out of a Holter report.
So there is a question from Dr. Amal Mahmoud regarding there is a rule of a tail table in patient with early rebolarization pattern in ECG?
Not that I'm aware of, Karim. I would like to have our colleagues' perspective on it, not that I'm aware of.
So I have a question regarding counseling the patient with channelopathy regarding two very important issue, which is sport and pregnancy. How would you counsel your patient regarding the activity and the pregnancy in different type of channelopathy?
As we have seen, uh, quite frequent forms of arrhythmias, namely the long QT and the CPVT, are treated with beta blockers. If your patient condition is stable and she's not getting recent ventricular arrhythmias or appropriate shock from a previously implanted device, it is safe to keep your patient on her beta blockers and allow her to get pregnant and follow her along cautiously during the pregnancy. It would be definitely advisable to shorten the second stage of labor during the pregnancy, and if this is impossible to be achieved, it's preferable that this patient be advised to go to a cesarean section instead of a normal delivery.
Thank you, Ahmed and Mahmoud. Again, the mic with you to continue your valuable discussion. Mahmoud?
Okay, we are coming to the end of our presentation. So this is the final slide from our presentations. In patients, for risk stratification of patients with sudden cardiac death, we have two important components. The first is the vulnerable substrate. The second is ventricular arrhythmias. So when you get a patient with vulnerable substrate, you look for ventricular arrhythmias, either by monitoring or if he is qualified for an EPS. You search for these arrhythmias to make this combination. So this combination has the highest evidence for benefit from ICD. The second scenario is when you get a patient with ventricular arrhythmia. So you search for this vulnerable substrate by means of imaging and other forms. And when you make this combination, you have this high evidence for sudden cardiac death with the highest class of recommendations. And that's all.
Thank you, Mahmoud. I want to hear a final comments from Dr. Ahmed Damati before ending this nice, great webinar.
Okay, give me 1 minute.
Final comment. It has been pleasure to be with you guys today. I hope we wrapped up about the issue of dealing with sudden cardiac death, aborted or syncopal episodes, or patients who had an arrhythmic substrate that put them at risk of sudden cardiac death. Be aware that your patient needs to have either um, a ventricular arrhythmia or a substrate. That is usually his presentation, and your role is to be looking at the other piece of the puzzle. So if your patient is presenting with ventricular arrhythmia, you need to be able to figure out whether this substrate puts him at risk, and then at the end of the day, he would qualify for treatment. If your patient is presenting with a substrate and is presenting with palpitations or syncope, you need to look for ventricular anosmia to be able to put the two pieces of the puzzle together and thus treat him accordingly. Thank you so much for your invitation, and we hope that this has been helpful.
Uh, Thank you, Dr. Mahmoud Abu Al-Ata, and thank you, Dr. Ahmed Damati. It's a really a hot, difficult topic. However, you make it simple with your valuable discussion and nice tables. So I think we have a three subjects of sudden cardiac death. The first is ischemic heart disease, and we revise the rule of prevention of sudden cardiac death regarding the primary and secondary prevention. And the second part of this nice webinar was regarding the different types of cardiomyopathies. And I think we have a clear demonstration of how to deal with each type regarding the use of ICD and different imaging modalities for risk stratification. And the last part was regarding the channelopathies, and we have a nice demonstration of different types of channelopathies and how to deal with. Again, thank you, Dr. Ahmed, Dr. Mahmoud. I'd like to thank also the CEC member, Dr. Muhammad Zahran, Dr. Abdurrahman Gamal, Dr. Haytham Suleiman, and Dr. Ahmed Saeed. I'd like to thank